With increased calcium bulk in coronary arteries, the chances of stent under expansion are much greater than less calcified lesions. Stent under expansion causes an increase in ischemic events at 1 year. It has been seen in large trials that in arteries with heavy calcification, the chances of stent under expansion are increased by 50%. Conventional non-compliant balloon works on a maximum pressure limit of 20 bars. At pressures of 18 to 20 atm, they cause balloon overgrowth and dog boning. Balloon overgrowth is a serious complication which may result in perforations and edge dissections. Dog boning causes serious implications as it creates high arterial stretch and leads to undistributed pressures at edges. Introducing OPN-NC, a CE-marked Swiss technology that shall redefine the strategies of plaque modification in highly calcific lesions. OPN-NC is an ultra-high-pressure plaque modification device that has a unique dual-layer balloon-in-balloon technology, which causes increased tensile strength and in turn makes it puncture-resistant. OPN-NC works at pressures as high as 40 bars and leads to uniform expansion and potentially no or least dog boning. OPN-NC has a controlled growth and may cause lesser dissections or perforations. The linear compliance of OPN-NC ensures uniform distribution of pressure. OPN-NC comes in a wide range of lengths and diameters to match all your needs in complex cases.
Welcome everyone. So we are starting again with the BIC Maharashtra chapter. So the next session is ultra high pressure plaque modification, and we have Dr. Rahul Sawant with us as the moderator. So Dr. Rahul Sawant is the HOD and the director for Cath Lab at Noble Hospital, Pune. Dr. Sawant has multiple publications to his name in both national and international journals, and he has worked across the globe in New York, USA, and England. And now he's working in Pune and will be moderating the session for us. Dr. Sawant, please start.
Thank you very much, Pankuri, for my introduction. We have Dr. M.S. Hiramat, Dr. Fusaro, and Professor Pascal Mayer will be chairing the session, and I'll be moderating the session. I'd like to introduce our chairperson, Dr. Shiresh Hiramat. He is a director of Cath Lab at Ruby Hall Clinic, Pune, and he has been a president of CSI from 2016 till 2018. Dr. Hiramat has proctored many intervention cardiologists and given many live courses across the globe. He has great experience in peripheral angioplasty and has participated in many groundbreaking trials. Then we have Dr. Fusaro. He is a senior interventional cardiologist at German Heart Center Munich. I had an opportunity to meet him in person when I attended German Heart Center Munich this year in January. Dr. Fusaro is also running his special CHIP course at German Heart Center. He is the biggest clinical trial center and animal facility in Germany. Then we have Professor Pascal Mayer. He is a head of cardiology at Cantonal Hospital, Switzerland. Dr. Mayer has vast experience in the treatment of highly complex cases like PCI with high pressure balloon angioplasty, rotoplasty, image-guided PCI, and left main plasty. Okay, with this introduction, I recommend that we start with our first presentation. First presentation is Learning from the Masters, Instant CTO, Upgrade from the Frontline by Dr. Fusaro, please.
Thank you, Dr. Sawant, for the great presentation. I remember that you were in Munich for our course at that time, and I hope this case, I hope that this year we can present the same, we can make the same. I hope that. Yep. And let's see what can happen with this COVID. So back to our educational point, is in this case the use of high pressure balloon, ultra high pressure balloon, and CTO. Is that possible, in particular in instant CTO? Let's go to the case. This is a guy relatively young, 60 years old, with a long history of peripheral and coronary artery disease. He started 2005 with NSTEMI. The colleagues stented with 3 stent cipher, at that time RCA, and 2 years later with LID, and a lot of instant restenosis tendency, treated with everything what we had in German standard at that time for basic evidence, for example, cutting balloon combined with drug-eluting balloon, high pressure balloon combined with drug-eluting stent, a lot of different interventions. 2015, we decided to put the patient 10 years later to the surgeons, and they put a lot of bypass, and a couple of years later, the bypass of the RCI was completely occluded. The patient had a depressed ventricular function with hypokinesia, but viable myocardial in the inferior wall. We stented already the CTO in superficial femoral artery. We stented the long occlusion also in the iliac artery. And let's start with the case now. The aim was to recanalize the right coronary artery. Obviously, after a lot of catheter, both radial artery, right and left, were completely occluded. So we decided to make the puncture of the stent. This is possible. As you can see, there is a long standing in superficial femoral artery, iliac artery, and also in the common femoral artery on both sides. So take care if you want to puncture the stent. Technically, it's possible. We try to use in this case 6 to 7 slender sheath in order to reduce the traumatic and don't perform thrombosis in the femoral artery and the iliac artery. This is the peripheral situation what we had. This is the coronary situation what we had. So we have a right Janskin's 8 French catheter in the right coronary artery. There is a long occlusion, completely stented right coronary artery. This is just a balloon put it like support or anchoring balloon in the conus branch, and this is the left. This is the left coronary system. There is a left main stent. There is an occlusion, the LAD. There's a septal branch, and there's a long occlusion until to the crux of the right coronary artery. So the standard approach in this case can be double, antegrade and retrograde. At that time, we decided to perform an antegrade approach. Antegrade approach for instant reocclusion means that you have to puncture the proximal fibrous cap. The proximal cap, instant reocclusion can be very nasty. So a lot of fibrotic tissue, a lot of calcified tissue, and a lot of stent struts there. They mostly are grossly underexpanded. This is the puncture, filmed puncture of the proximal fibrous cap. This is the progressing with difficulty of the cap. This is a CP12, compared to Pro12. I suggest for such fibrotic and very calcified lesion, nasty lesion, very arc-wide, for example, Gaia 3 or CP12, first choice, but after of attempts, it was impossible to cross forwards with any kind of wire, what we had. So this is, for example, hydroslips wire, Friedrichs TA, Pilot 200, only 14, everything we tried, but was not possible to cross there. So we have 2 options at this point for instant reocclusion: knuckle wire technique or retrograde. So I thought, okay, I tried knuckle wire technique. Which is knuckle wire technique? You create like a knuckle with your wire, and you can see in this picture. This is the knuckle there. Okay. Check in 3-dimensional view in different projection. Thus, the knuckle is inside the stent strut. What we did after that, simply push, 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 push. This is the only way to recanalize the stent, is to push like in this fashion. This is knuckle wire. The knuckle will be bigger, but it's not a big deal because there are the stent struts that protect. Thus, you create a big subintimal space. Okay. So this is the last picture what we had with subintimal tracking. Let's make a pause there. So there is a knuckle wire until almost to the crux, but not crossing around the crux because the section will be very big. stop before your re-enter point. And at this point, we have two options: go retrogradely or progress antegradally. Like, I'm sorry for the quality of the description, but this is sorry. This is just to see which is the way to progress antegradally. Your entry has to be absolutely clean. You, at that point, is not allowed that you go subintimal anymore. You performed a lot of knuckle wire. This is a Gaia 3 millimeter per millimeter, very fine manipulation, and you cross intraluminal like in this picture you can see. It's not allowed to re-entry point to make subintimal tracking forward. So if you have the feeling, I'm going subintimal, please go retrogradely. So you changed your microcatheter, you pre-dilate with a 25, high pressure balloon. This was okay, this was a big deal. So I decided at that point to pre-dilate because of the presence of a lot of material. This is a 30 OPM balloon expanded until 35 atmosphere. We pre-dilated the entire length of the stent. The whole length of the stent was pre-dilated, but approximately at that point, it was something that gave me the feeling that is what not correct, because the balloon was not completely expanded at that point, like here. There's a completely expanded OPN balloon, and the proximal part is not completely expanded, so I performed an IVUS. So this IVUS moving from the right side to the left side. This is a particular IVUS to give you much more information. This is just the distal part. The re-entry was intraluminal. There is two stent struts from previous intervention. Then we are intraluminal, clear. The middle of the right coronary artery will also intraluminal. That is clear. There is a lot of material inside, a lot of smart muscle material, fibrotic tissue, as we can see. But in the proximal part of the artery, this is a clear picture. That's what I thought. Okay, what I did. You can see the stent completely crashed there. Again, the anterior wall. This is, if you look to the horizontal part of the artery, the stent, the subintimal tract, begin from here to here. There is at least 20 millimeter completely subintimal tracking in the proximal part, where I manipulated Gaia 3 and Confianza Pro, and I went subintimal. I crossed around the stent. I pre-dilated with high pressure balloon, and this is the result in the proximal part of the artery. To be much more clear, this is the stent completely crashed again the arterial wall, and we can see angiographed this picture. So this movement, this from this segment until this segment is at least 20 millimeter completely subintimal. So I crossed around the stent. I was able to re-enter. Please don't ask me how. I don't know, but this was the truth. And what you can do, you have recanalized, you're successfully recanalized. What I did at that point, I progressively dilated the subintimal space. This is a 3-5 balloon, OPN balloon, expanded at the 30 atmosphere. Why that? The stent struts of Cypher had 4 connections between the stent ring. Instead 3, for example, of new generation stents. Someone at 2. The stent struts of Cypher, this is a Cypher, put it more than 15 years old. Cypher is very nasty to dilate. So I progressively dilated the subintimal space in order to make more space and put a stent there. Second aim was to crack the stent struts of the Cypher. And you can do that with very, very high pressure. So there's a 3-5 balloon. There's a 4-0 balloon dilated under 40 atmosphere. And this is the angiography after the very aggressive pre-dilatation. There's something written in the proximal part of the artery, but it's not perforation. There's not rupture of the artery. I was happy with this picture. I have to be honest. So the second point was to put a couple of stents. This is the putting of the stent at the distal part of the artery. And this is the putting of the stent until to the ostium of the right coronary artery. This is the final angiographic result. Nothing spectacular, but the teaching point here is the re-angiography at 6 months. We perform for every CTO, in particular for subintimal tracking, re-angiography. Let's keep a little bit attention. We can see the first stent, the second stent, and this is the re-angiography. This is incredible. the subintimal tracking, the subintimal dilatation, again, subintimal tracking, subintimal dilatation, and subintimal stenting is safe if we do that progressively, and there is no restenosis. The restenosis is just in the distal part. If we remember the distal part, we were completely intraluminal, completely expansion of the stent. This is for sure the result after 3 drug-eluting balloon. That OPN pre-dilatation was nice, but I was surprised to see that the proximal part of the stent had no restenosis because I stent the subintimal. What we learned, this is the overview. In-stent CTO, please, is not so easy as it looks. Please don't have the misconception that in-stent CTO may be easier to cross than de novo CTO. This is completely false. In many registry is demonstrated that only with additional expertise, the results of in-stent CTO can be comparable with de novo CTO, as we saw in this case with knuckle wire, for example, technique, and safe distal part of reenter. So additional expertise for in-stent CTO is required. Why? Because the occluded stent tend to be grossly underexpanded. I put a 4-5 stent, and the colleague at that time, 10 years ago, they put a 3-5 stent in the proximal part of the right coronary artery. Because stent fraction or disruption or metallic can make the wiring and delivering of your equipment challenging, particularly if you work with the OPN balloon can be bulky. CTO with a long chronicity history, like in this case, are often associated with arthrobrotic tissue and a calcified lesion. And we demonstrate in the proximal part the wiring with Confiance Pro was very, very nasty and very difficult to do that. So, what I personally learned from the case, subintimal tracking, also in in-stent CTO, is possible and safe if you do that carefully, not like an animal. Don't delay the subintimal track like a beast. Progressive balloon dilatation and the pressure is much more important. So undergrade your balloon 0.5 millimeter less and go high pressure. This is the philosophy of OPN also, high pressure. Extensive and mandatory use of intravascular imaging. Otherwise, you cannot understand what happened in the stent. If you recanalize an occluded stent, please make an IVUS, please make an OCT, whatever you have, do that, because don't be just with angiography satisfied. Subintimal dilatation and stent is safe. We saw at the beginning that I completed the first stent against the arterial wall. I broken the connection of the cipher and I crashed part of the stent against the arterial wall. This is possible and safe, but like before, not like an animal, carefully. Angiography follow-up is strongly recommended in this case, in particular recanalization of the stent occlusion. Despite the patient have no complaints, please reschedule the patient for the re-angiography at 6 months. This is the lesson what we learned in German Center. I thank you, dear colleague, for your attention. Thank you very much.
Thank you so much for an excellent case, a very challenging case. One of the questions which has come up is it safe to use ultra high pressure balloons longer than the lesion in length if the diameter of the balloon does not exceed the diameter of the vessel?
Yes, this is the trick. This is the reason why I suggest IVUS. With IVUS, you can give you the possibility to understand how big is your artery and how you can dare with your balloon in terms of diameter and pressure. Normally, to crack the stent struts of cipher, you need pressure because the cipher is very nasty. Stent struts of cipher, all the first generation are very, very resistant. So you need very high pressure. So go down with your diameter of balloon and go high with pressure. This is safe. Yes, this is safe. But nothing is safe. This is a procedure, as Dr. Saban said, extremely complex, and you take a couple of hours of time. You have to be prepared also for complications.
Okay, that's great. Thank you. The second question, would you prefer to image the vessel size before upsizing OPN balloon to avoid perforation?
Yes. Absolutely. Yes, you have to estimate the vessel size with the first redilatation of the stent. Personally, if you have the history that you have a 3.5 stent implanted, you can safely dilate with 3.0 OPN balloon. Nothing happens normally because the stent is 3.5. So you can also postpone your IVOS, your imaging after the pre-dilatation with OPN. But I suggest to do before you start with OPN balloon, make a run of IVOS and give you a much more complete idea, which is the diameter of the stent, what we did also. So imaging, as far as possible.
Okay, thank you. The third question which has come up is how to escalate the pressure during OPN NC inflation. So what pressure and what pressure you go up to? How would you judge that?
Yes, this is a nice question. So there is like a feeling and until 20 atmosphere, what we make in German center, until 25 atmosphere is ever balloon safe, because also a normal balloon. The OPN don't increase the diameter until 25 atmosphere. Up 25, 30 atmosphere increase a little bit the diameter of the pressure. But I make always the same simple example. If you have a 10-0 balloon expanded with 3 atmosphere, you exploit the artery, you break your artery. So it's not the pressure that exploits the artery, but the diameter of the balloon. So if you downsize your balloon, it's not a big risk to make perforation. If you make 1-to-1 and go with high pressure, now you have a risk of perforation. So downsizing of your balloon, particularly for OPN. So 3.5 stent, 3.0 balloon, 40 atmosphere, up 25 atmosphere, 5 atmosphere, 5 atmosphere, 5 atmosphere, and check your imaging with your angiography. If you expand it at 35 atmosphere, you don't need to go up the 45. I mean, this is completely feeling what you have with balloon and angiography.
Anybody else wants to ask before I ask the next question? Any comments?
Fusaro, you decided to image after initial balloon dilatation.
Yes.
Because at the back end, the balloon did not expand the way it expanded distally. So what crossed your mind at that time? I mean, you did imaging and showed everything that the first initial part was substrate, but just with the balloon, what crossed your mind?
At that time, I have to be honest, that was a live case. And during the live case, after 1 hour crossing the wire, and during live case, you have just 30 minutes to finish your angioplasty.
Yes.
This was the reason why I decided to pre-dilate with OPN balloon and after to do the IVOS imaging. Normally, I don't suggest to do that. Pre-dilate with balloon and perform it before you use the OPN balloon your imaging. This is much more safe. But at that time of this live case, I was very late with the time, more than 1 hour crossing the wire. And so I decided to pre-dilate with OPN balloon, and after that to put the IVOS after I saw the problem in the proximal part of the artery. This is not correct. This is not correct what I did. I have to be honest. Correct is perform the first pre-dilatation and imaging. This is the right consequence to reduce perforation, to reduce rupture of the artery. If you dilate with a very high pressure balloon, OPN balloon, and after that you do the imaging, it's also safe. I did that because I know in the proximal part we are just a 3.5 stent, but I risked that. It was not correct. Pre-dilatation with small balloon and IVOS is safer. That's what I did at that time. That was not the right way, but it was a live case. I don't want to justify myself, but was wrong. You are right. Yeah. You have the right predilatation and IVUS.
Yeah, can I ask one question? About the vascular access. So how did you manage? How was it sealed? And because the stent, so the femoral access, which you showed us, that through the stent you went inside. So how did you then manage that?
No, thank you for this question. Thank you very much. Because we are mostly interventional cardiology, but most of us can make also peripheral angioplasty. This guy was a very, very poor guy in terms of peripheral situation. I did the revascularization of the peripheral artery at that time personally, and I promised to him that I removed personally with my hands, just manual compression. Manual compression. If you want to make safe the stent puncture, do the compression by yourself, because you know what you did, you know which is the anatomy, you know that's the stent, the self-expanding stent. If a not experienced cardiology make the manual compression inside, the risk of the stent is completely to crash, despite the self-expandable stent. So you have to have such sensibility to make the compression, right compression, don't make hematome, but don't crush the stent in the groin. So my suggestion, if you decide to put the puncture of the stent, do personally, take your time. It's a nice time. You can speak with your patient. Do personally the manual compression. It's safe because you know what you did. If someone else do that, it may be that you have to go in the night and reopen the groin. What also happens. What also can happen. So safely puncture and radial shift. Radial, small shift, radial. I suggest radial, slender shift. Personal manual compression with your hand.
I would like to ask one question, please.
Sure.
You also prepared for retrograde access if you are unable to cross antegradely. But what will be the role of crossboss here rather than going retrograde access? Can we use a crossboss over here if you are unable to cross with wire?
So the crossboss is very bulky. If you want to put a crossboss before you start such kind of revascularization, so go to the basic. Crossboss is allowed if you cross in the native artery and puncture of the subintimal tracking with crossboss wire. In this case, it was very, very difficult to put the microcatheter in the distal part of the artery. I cannot imagine to put crossboss first. Second, bifurcation reentry normally is an indication for retrograde. We have to understand that.
Okay.
In this case, I make just one single attempt to go antegradally to make the puncture of the distal fibrous cap. What I did. Maybe I had just luck. But in case of a long manipulation of the distal puncture, so don't waste your time, because the risk to expand the hematome and occlude your re-entry artery is very, very high. So don't waste your time. 5 minutes attempt. If you cross clean your distal cap, okay. Like in this case, if you don't cross, if you are not able to manipulate the wire from distal part of the artery, clean, please don't waste your time. Go retrogradely. It's a couple of seconds to delay with your retrograde balloon, delay your crux cordis and make very easily re-entry. So in this case, yes, it's possible to invest 5 minutes of time, but just with the puncture of the distal cap. No way for crossboss or stingray, because very, very nasty. Very, very nasty.
Okay, I think in the interest of time, we should move on. Okay, the next presentation is by Professor Pascal Meyer, Learning from the Masters.
So there is some issue, some network problem with Dr. Pascal. He's trying to join back. We can start with Dr. Hiramat's presentation.
Sure. So we'll take Dr. Hiramat's lecture, Learning from the Masters, Making Difficult Lesions Effective and Safe with OPNNC. Hiramat, sir.
So hello everybody. I'm going to be showing you some cases where OPN balloon helped us, and probably can be an indication that we should be using this balloon under these circumstances. Where is my top pointer? Just give me a second. All right, so we heard a little bit about the OPN balloon. And as you all know, we have two layers. So does this two layer make it sort of resistant to perforation of the vessel? Well, this is a very important issue. Even with high pressure, you perforate from within, or you perforate from the outer coat because of calcification, maybe a spicule of calcification. I think the two layers sort of don't allow the contrast to blow out into the beyond the vessel. So perforation probably would be limited to the adventitia and will not go beyond. So giving you enough time to sort of gather yourself and change your strategy. The other thing is the dog boning, which happens, and it hurts the intima at this point beyond the balloon. Or if you put a stent, again, this point is notorious for perforation. That dog boning is not there. It's a clean line, and that's why perforation is rather uncommon. So this is how the balloon does not swell. That is most important. And you can see here the OPN balloon, even if you are going very high on pressure, it is not swelling. While other balloons seems to swell, and that is the reason why they perforate. So this is the difference. At 10, you're here, and at 20, at 35, you're hardly grown. So not growing in diameter is very important. This is one case. If I show this to some of the Japanese operators, they would say that this is Kawasaki's, because you can see coronary aneurysms. In addition, there are critical narrowings. So this gentleman was 37-year-old, and the Japanese strongly believe that these are very hard lesions. You can see the aneurysm in this portion on the OCT, and critical lesions a little bit beyond and close to the aneurysm. So we knew we have a hard lesion at hand. So after preparing the bed with OPN at a good pressure, this is the stent position, and the same balloon was used to post-dilate the stent, deployed stent. So the OPN is very notorious. I think many of you must have experienced this, that when you have when you are going high on pressure, it grips the wire from within. So one of the recommendations is you do not use a hydrophilic wire when you are using an OPN balloon. The gripping of the wire from inside is not a speciality of OPN balloon. It's any balloon you go high pressure, it will start gripping the wire. So there are people who believe that we should put another wire on the side, so that if OPN balloon pulls out this wire, you have a protection wire on the side. Then this patient was attempted outside, and they could not get this waste out. So the balloon, the non-compliant balloon, had this waste. So we had an option of going with OPNNC. There wasn't too much calcification at that point. But because of the previous experience, we did ROTA, and then we used OPNNC balloon. And that's the waste. You can see the waste go very quickly. So this is the final result on this case. So you can combine the OPN balloon with ROTA. You can combine it with a shockwave balloon. Then you can have a combination of cutting or scoring balloon with an OPN. And this is how you can actually work it out. This was a 10-year-old occlusion, or maybe a little bit more. You can see some calcification at this spot. And we had various options to go through. So this was addressed with Nic Nano Hydro, which is again a non-compliant balloon meant for CTO. And this is actually what's called crossed with the guideliner. And the IVUS showed that most of the calcification was adventitial. So instead of doing IVL or ROTA, we had, I think IVL was not available that time, but we used OPN balloon, and this is the final results. A big circulation was opened up. This was an elderly gentleman with sizable calcification in all these areas, including left main and a dominant left circulation. So here we did IVUS, of course, and since there was so much calcification, we decided we'll do a rotablator. And rotablator was followed by OPN balloon. And this is the final result with multiple stents, including a left main bifurcation. This is the IVUS post stent indicating a very good expansion of the stent. So OPN balloon, most of us use it pre-stenting, but can be used either ways, pre and post. In this particular case, you can see a gap after a non-compliant balloon dilatation between the stent edge and the vessel wall. And this is where we again used an OPN at high pressure to get a good result. So when the stent is malapposed, you calculate this area. This is a maximum area. And if you have a sizable area which is sort of hanging like this, I think the possibility of stent-related problems are plenty. This gentleman, 3 years back, had an ostial stent in the circumflex. The operator felt that he had put a stent right from the ostium, but you never know whether the stent is coming back. And now he has come with a narrowing of the ostial LAD. By definition, this is still ISR. And when you do a stent boost, you can clearly see the stent is coming back a lot towards left main. So it is actually in front of the LAD. So this is how it is. So you have an option of going through, push the stent strut towards the opposite wall and do what can be called as culottes. Or you can actually crush the stent here and do a mini crush. So we prefer to do a culotte. So our balloon actually has gone through the stent struts, as you can see on stent boost. And then we use the OPN balloon to dilate the LAD stent, and also used it for kissing balloon along with circumflex stent. So this is the final result. So this is how it was when we started the projecting stent. And this is how we ended after doing a culotte. This is actually a mini culotte, you can call it, because the protruding stent of the circumflex is pushed against the opposite wall of the left main. This is not the same case, but this is how the CT is so good, you know. This stent was placed again 7-8 years back. Now patient comes with a narrowing in this portion. And we could not get this stent in from left main to the distality of this stent. So we finally we managed, did some balloon dilatation and did this. And this CT was done a few months later just to check the stent, as well as why we were not able to get the stent in. But this is how it happens. When you try to do osseal stenting, these are some of the problems that come up, that you are a little bit precautionary and proximal to the osseal. This is again an outside case where osseal LAD stent has been placed, a very dominant left circumflex circulation. And you can see a few months later narrowing at the mouth of the circumflex, which was not there at the end of the procedure. So this is again a protruding stent of the LAD towards left main, which has led to an ISR. You can see the osseum of the circumflex is critically narrowed. The circumflex mouth narrowing, even in a native vessel, is quite a difficult problem, but in presence of stent, it is even more difficult. So here we have wired the circumflex from proximal of the protruding stent. This was confirmed on the stent balloon. An OPN balloon was used, scoring balloon was used afterwards, and two stents were one stent was placed, and the LAD stent was checked again. So this is the narrowing at the mouth of the circumflex, and this is at the end of the stenting, that the mouth is fully open. This is the LAD stent, and you can see the LAD stent along the entire length appears quite nice. So we were quite careful not to hurt this well-functioning stent by using high-pressure balloon. So you can see here the LAD. The stents are well opposed at this place. The OPN balloon is also very good when you have this kind of situation like this. On stent boost, we have used NC balloon at high pressure, but still there was a gap when we had done a culotte stenting at the left main bifurcation. To fill up this gap, we did pot with an NC balloon, did not work. This is how we were, but with an OPN balloon, we were able to get this gap completely opposed, and the two stents are now touching each other. So for pot also, the OPN balloon comes very useful. Like you can see the balloon just at the pot position and opens up the side branch very well. Now this is when I was called in to the operator had landed like this stent, which is unexpanded. So obviously this is under preparation of these before you take the stent. And at this stage, I think OPN kind of balloon can come useful. This is of course we did not have an OPN balloon at that stage. So the underexpanded stent can lead to lots of problems, including stent thrombosis in the immediate post-PCI period and ISR at a later date. This was a case where we did a rota to the proximal RCA, but we had lots of issues, like we ran into slow flow, no flow, and we had to spend a lot of time to stabilize this patient. Patient also had a right lesion. So this big circulation was stabilized with a stent in the proximal portion. And then when we wanted to do, this is how we ended on the right. And when we wanted to do the left circulation, which shows sizable calcium, we thought we'll avoid rota because we did not want any embolization in the left system. So we used an OPN balloon and we had a nice result, as you can see here. So this is a precaution. Now this bifurcation with calcification, no, I think this slide has come here by mistake, but this is a bifurcation with calcification in that area. You can see the calcification towards the end and also at the beginning of the frame. So in those days, we used to do a rota to one of this, like LAD got a rota. Once rota was done to LAD, we put another wire to diagonal and use a flex tom balloon there, because we did not want to remove the wire. But I guess with experience increasing, we can do one by one rota, and we can switch the wire from one to other. But this is how we ended. But I wish at the end of rota and a cutting balloon, we had a OPN balloon which could have prepared the bed even better, though we had a decent result in those days when this was not available. This was actually a shockwave balloon. You can see the patient was a long-standing diabetic, small, relatively small diameter vessel. This is a 7 French catheter, and you can see the left main diameter is quite small. And you have lesion at the mouth of the LAD as well as the mouth of the circumflex. Again, we did not want to remove our wire after rotablator, so we have used a shockwave balloon towards LAD, shockwave balloon towards circumflex, and then ended up with a decay crush to get this kind of result. So whenever you don't want to remove your wire, you think of these kind of techniques. So this is another area. Patient had a functioning lima to the LAD. However, that LAD was a small portion, and the proximal portion of LAD was giving rise to sizable diagonal branches, which was giving him angina a few years after the bypass surgery. The patient underwent an SKS technique. We generally don't do that, but this was a live course, and I think the operator decided to do an SKS, in this case after rotablator. Patient came back with an ISR. Surgery was not an option. But you know, in SKS, you have 2 lumens. So we were able to wire both the lumens separately towards the diagonal LAD and towards circumflex. However, our balloon could not go towards the LAD diagonal. So we decided to crush, and you can see all the metal gathered on one side, and then through this, our wire had to go. Now, when you are doing these kind of things, you need to do, like you can see here, we have 2 balloons. That time, we had only non-compliant balloons available to us. But if we have OPN balloon, I think we would have probably prepared the bed nicely. You can see in the final analysis, stent running towards circumflex, and a couple of stents going towards LAD and diagonal here. So this was how we salvaged, and patient remains quite good. So the OCT assessment of ISR is very important before you make a choice as to what technique you're going to use. Most of the time for ISR, you use cutting balloon and a high pressure OPN kind of balloon. But these days we have IVL also as an option. This actually is a critical guide, the intravascular imaging, as to what technique you're going to use. But this helps us decide the possible help from OPN kind of balloon. So this is a bifurcation decay crush coming after 6 months with a very focal stenosis at the mouth of the circumflex. Again, a fairly important vessel. And this is the IVUS towards the circumflex left main pullback. So we decided to put a drug balloon. So in this case, we used a cutting balloon followed by an OPN balloon, and then a gentle kiss towards LAD at low pressure. So the advantage of ultra-high pressure balloon like OPN is there is a very short learning curve. The stent optimization is easily possible, and optimal calcium location If it is an intraluminal calcification, you can get a good result. There is a low possibility of slow flow, no flow kind of reasoning with an OPN balloon. So under all these comparisons, OPN seems to do well compared to cutting balloon, rotablator, and probably IVL. Has OPN-NC, which are the most physician-friendly tool that we have today. So these are the multiple algorithms when you have calcified lesions, but OPN balloon along with something else like rota or IVL find some role when you really want to expand the stent. About the diameter, you have already seen this. You can get 1.5 to 4.5 diameters. The profile is quite small. The balloon crossing profile is quite small of the OPN balloon compared to a cutting balloon. This is 0.71, while cutting balloon is 1.04 and upwards. So I think it can reasonably quickly go through a critical narrowing. This is actually just for comparison, but high pressure balloon inflation can be quite good. Many people put a wire on the side just to be more careful. This was a 9-year-old crush, mini crush, stent in LAD, a stent in the mouth of the diagonal. The stent boost looks reasonably good, and even on OCT, the diagonal mouth appears quite good with LAD stent well expanded. So this patient has come with a narrowing in the proximal portion of the old stent in LAD and also the orchial lesion. So we have to put one more stent here. So obviously there's going to be a double layer in front of the mouth of the diagonal. Since the diagonal mouth was fully widely open, we could sort of dare to do this. We did a sort of kiss towards the end, not a high pressure towards diagonal. And you can see these are the two layers in front of the mouth of the diagonal, and diagonal flowing well. Now, many times when you are doing multi-vessel stenting, this kind of lesion here, as you can see in LAD, it looks easy, but it would need something more than an average balloon. Also, as you go more and more distal, vessel narrows and gets harder and harder. And these kind of lesions also will need something like an OPN balloon. This was an ACS from a proximal LAD. You can see calcium plus thrombus in this area, again addressed with an OPN balloon. And also, when you have poor ventricle and calcification, I think rota becomes a big problem, big challenge. So some of the tips are consider putting wire on the side when you are using OPN balloon. Then generally avoid polymer sleeve wires like Fielder XT or Whisper. And in calcified lesions, very often more pressure is required rather than more diameter. I think this is what everybody has been emphasizing again and again. Don't chase with 1-to-1 diameter. You go half size smaller and go higher on pressure. We have actually gone to 45 many times, and you can use the same balloon for pre-dilatation as well as post-stenting for post-dilatation. Thank you indeed for your attention.
Dr. Hemant sir, thank you so much for your excellent presentation. Very nice cases and a lot of things to learn. I've got a lot of questions coming up for you. So in your experience, can you please explain which are the indications of OPN-NC balloon?
I think whenever you think of a harder lesion, I think you should go for an OPN balloon. If there is, I think imaging is very important to choose between IVL and rotablator, and supported by either an OPN balloon or a non-compliant balloon. So I think under these settings, I would feel that imaging will decide. But whenever you want high pressures, Then, as I showed, if you do not want to withdraw your rota wire and put it in another wire on a bifurcation, again, you can use rota on one, cutting balloon on the other, and do both with OPN balloon.
Another question is, if you are a new learner or relatively young interventionist, obviously people are worried about going to high pressure. So one of the questions to you is, any tips on using optimal pressure and what pressure you go up to?
Yeah, as we discussed, you go slightly undersized, not very undersized. And then you can go high pressure up to about pressure of about 25. You can go at regular speed. But when you decide to go from 25 to 45, I think you need to be very slow. You keep watching this fluoro. In fact, I don't trust anybody when I'm inflating the OPN balloon. I do it myself, because the moment you saw the vessels getting suddenly stretched, you know that you are in trouble. So that is an adventitious tip. And if you are able to control the inflation at that stage, I think you would avoid perforation. It's not that OPN balloon is perforation proof, but I guess a lot less compared to a conventional NC balloon.
So visual and tactile feedback both. And if you're an experienced operator, I think tactile feedback, as you said, is very important. You cannot just give it to somebody else.
Yeah, I mean, as you said, you should know when to stop inflating, you know.
Another question is, you've got so many things now, OPN, NC, IVI, rotablator. Which device would you choose for a lesion? So how do you judge that?
I think when the lumen is very narrow, IVL balloon will not go through very easily. In that case, if there is a calcium in the lumen, I think rotablator comes very useful. And then rotablator, if there is a deep calcium, also extensive deep calcium, I think rotatripsy, as we call it, rotablator with a tripsy. So that's a combination that you can use. But most of the time, I think we are all these years we are doing it with rota and a conventional non-compliant balloon. So today we have rota with an OPN balloon. So I think this combination is quite a strong combination to handle most of the calcifications.
That's great. Thank you. Thank you so much. These were the questions for you. Excellent presentation, sir. Thank you.
Thank you, Rahul.
Now, next presentation, I believe Professor Pascal Meyer is here. Pascal Meyer's presentation.
Yes, I'm here. Now
Okay.
everything is working. Sorry for that, some technical issues.
No problem, sir. So your presentation is learning from the masters. So we'd like to hear tips and tricks from you. Over to you, sir.
Okay, thank you. Oh. Just a second. Now I have to.
So if there is a time, I'll ask one question which is already there for Dr. Fusaro. How would you close a groin which has a stent? So that's a question from audience. So there's a SFA stent or a CFA stent. Will you use a closure device?
No. We use a manual closure device.
That's correct. You should not use a closure device in such
No.
circumstances.
No.
You're likely to close the vessel if you use a closure device. So it's no.
Manual seal.
Okay. That's great. I think seems like Professor Pascal Meyer has a problem. Pankuri, can you please update if he has a
Let's
problem
start with another presentation.
We'll go with Dr. Sachin Patil, accessing complex CTOs using Nick Nano Balloon practical approach. Sachin, are you there?
Yes, Rahul, I'm very much there. Let me start sharing. Okay, so
Sachin in Kolhapur, and he runs his own center. Great interventional cardiologist.
Sorry.
Over to you, Sachin.
yes, thank you, Rahul, for the kind words, and good evening all, including my favorite teacher, Dr. M.S. Hiremat. So this is a 73-year-old male diabetic and hypertensive. He underwent a CABG in 2001. So that time he received 3 grafts, that is Lima 2 LAD, PDA and OM1. And now he's back to us with class 3 angina since last 3 to 4 months. So this is his picture in 2001. If we see here in 2001, that there was a big side branch followed by a CTO or 100% occlusion with some bridging collateral. So that says that was a CTO even at that point of time. How much before, we don't know. There was a 50% lesion, 70% lesion, and these two. So rightly at that point of time in 2001, he was sent for CABG. And this is his picture now. So we see here that circumflex is a bit smallish vessel, totally occluded, and the LAD is again totally occluded. Grafts are working well. There are no retrograde collaterals whatsoever to RCA. Then this is the RCA picture, which shows a calcified vessel. Here it is that proximal 50%, and this is a very blunt CTO ending right at that large acute marginal branch. If we see here, we can see that it ends there. Just to take another view. So this is a RAO view, shows that again it's ending in a blunt plaque, and we can see here it's a practically a tram track calcification. So we are probably dealing with a very calcified, old, and a blunt stump. So this is now injection through a graft. So the graft, because it was a SVG graft, now it's almost since 20 years. So the proximal segment is quite deceased. Even the distal segment is deceased. See here, it's quite deceased distal segment, and even the proximal. And then the graft was given to PDA, which itself is deceased. So there are no retrograde collateral from LAD. So retrograde is out. Then retrograde from graft into this is again out, because of this is a very bad segment, unhealthy segment at 2 places, and given to a PDA, which itself has a disease and angulation. So we are left only with the antegrade approach. So if we analyze the score, it's a perfect blunt tip or a stump where we don't know the true lumen where it will be. Huge amount of calcium, occlusion length more than 20 millimeter. So category is very difficult, and antegrade success rate is about 50% if we go by theory. But that seems to be a best option at this moment of time. So this is the retrograde injection, first through the graft, then through the native. Again shows that, okay, this is the blunt stump, followed by somewhere till here, there is a retrograde dye going, and there is a disease. So, and huge amount of calcium there. So I started with first, I parked my wire into large AM. As we can see here, this is a 7 French AL1 engaging. Just to get idea from where it is deflecting, I parked one wire, which will give both support, stabilization, and some guidance. So initially I thought, okay, if there is some channel, I will explore quickly, which was less possible, but tried a filter XT. Obviously it didn't help. So I changed quickly to Gaia 3. Now the issue is why Gaia 3? Because if we analyze here that it's a calcified segment, and confianza or this thing works by a penetration strategy, while it will just penetrate in a straight length irrespective of a plaque composition or calcification, while Gaia works by a deflection strategy or a intimal tracking strategy. So where you have to rotate, deflect it, and then go, and still those stick to the lumen. So I don't want to be very harsh, especially when I don't know where to, and the amount of length was very high. So we have to be very careful about these penetrating wires when we have a long length. So that's why I choose a Gaia, because this wire was there and I was trying to explore somehow I could get into some length. This is a Caravelle and this is a Gaia 3. So after that, I thought, okay, reasonable, the tactile, good feedback. I could cross well into the vessel across the branch, making it sure that I am in lumen, and adequately it was confirmed by the retrograde injection that I am in a true lumen. But the now issue was that the caravel was not tracking. It's still there. Then tried through another wire or balloon or this routine balloon and all, everything was just backing out. So then that point of time, so we have a wire which is there in the distal lumen, but micro is not crossing. Reason obviously being a calcium and tortuosity. I feel still that caravel doesn't give that support or strength as a micro or fine cross would have given. So option at that point in front of me are three. One is rotablation because of heavy calcium. Wire is across 004. So I can very well go with the 009 wire of rota and do a rotablation. Then a tornus catheter with an anti-clockwise torque, whether to dilate the channel, or Nick Nano. That was 0.85 balloon. So instead of again getting into the complex machinery, I thought let me just explore with the Nick Nano. So as you see here, the Nick Nano with some deliberation and here and there, it just crossed into the distal segment. So it gave the way. And once it was high pressure dilated to 2030, it gave a good thing. And then now my caravel is across, the routine workhorse wire is in, and rest of the thing was, I thought, okay, let me, once wire is across, cardiologist is king. And then the proper CTO segment was dilated with 2.5 by 15 NC at 22 atmosphere, routine NC balloon. And then this is a 48 mm stent, which was not going right at that spot. You can see that everything is just backing out. The guide is backing out. So that point of time, again, I changed the strategy, came in with 2.5 by 15 OPN balloon, dilated at 35 to 40 atmospheres, 2 to 3 dilatations in a serial fashion. And then this is a 48 mm stent we just walked through after that OPNC dilatation. So this is the picture after 2 stents which have been put. Now PDA is, we know that it was diseased from the graft. Distal is quite fine. And if we can see here, there is some segment of, under expansion where there was that 50% lesion. So it was like, it was not giving that good picture. It was like stains on the moon. So I thought, okay, let me do something more. So I thought, because this stent was 3.5 into 48, I thought, okay, let me take 3.5. This is well around 4. So I tried with 3.5 by 10 at 45 atmospheres, 3 to 4 dilatations, but it did not yield because probably it was total, circular calcium 360 degree, and that's why it did not yield that much. So at that point of time, I thought, okay, let me just leave it and plan shockwave lithotripsy later on if he comes back with the issue. So at that point, I accepted the result of little bit of under expansion at this, but well opposed stent, now under expanded, and a good distal lumen and a big RCA circulation was opened up. So at the both point where Nick Nano helped me and even the OPN NC helped me in getting the stent across. So that was my case.
It's an excellent case, Sachin. Thank you for a nice presentation. So I see in such cases, do you use long sheath? So where you need a good support?
Yes. So in this case, or even most of the similar cases, I use 55 centimeter long sheath, 7 French and a good 7 French guide. Plus, because it was a very old CTO calcified, so I was prepared with the 7 French sheath and AL guide.
So it's important to have a good support that makes operators' life much easier.
Absolutely. I think the hardware is the one which makes our life comfortable and change from an unsuccessful to a successful case, like in that case.
Yeah, definitely. You had a very good guide support. What is the advantage of Nick Nano over other CTO balloons? That's a question from audience for you.
Yeah, because the crossing profile is so fantastic. See, once is the profile which is very low, two, the cone is long, so it tends to dip in. So sometimes we say it's like a leopard crawling technique where you dilate inch by inch and then go ahead. While and second advantage is once you're across, you're dilating at 30-35. So at 30 atmosphere, it just gives way. And then next to your hardware goes very easily. As we saw that the next time the Caravelle did not have problem till the PLVB and I could exchange. So the balloon profile is very good and cone. Maybe a senior or MS can add up into this.
Yeah, Sachin, I was going to say that, when you nose into a CTO, you go as deep as possible. But even if you're not gone too much deep, you inflate. And Nick Nano has an ability to sort of keep pushing itself forward. This does not happen with the conventional 1.0
Balloon.
Compliant balloons, but it can happen with Nick Nano. I would feel it's the smallest length available is 5, but I always take a slightly longer balloon because once you go in, you have some kind of push and you need to push in then and there. You can't pull it back and then push it again. So once you're inflated, keep pushing it forward. That's the trick. You did not use Guidezilla. You didn't think it was necessary? I mean,
no, because the proximal once it was dilated and maybe that 55 centimeter sheath and a 7 French guide, which is AL, was probably supporting me well. The only thing Guidezilla came into my mind before when that stent was not crossing after 2.515 NC dilated at 22 and the stent was not going. So at that point, option was either a Guidezilla, but I thought, okay, let me use another OPN. And once that OPN was dilated, the stent just walked through. So then subsequently, I did not require any Guidezilla.
the other thing, the last thing you could have tried was put a wire on the side of when that proximal one was not getting expanded. Maybe you could have put wire on the side and then gone up with an OPN balloon at high pressure. Sometimes this presence of little metal helps and you could have got a good expansion.
Yes, I think that would have been. But my thing was that probably it was a total 360 degree of calcium, and that's why even at 45 atmosphere it was not opening. Maybe Dr. Pascal, what's your opinion on that?
So can you repeat the question again? I just tried to again fix some technical issues here. Sorry.
Yeah, because the calcium was ring 365 degrees. Even you go how much pressure, sometimes it may not give up. Or if it gives up, sometimes it may give in a very odd fashion. So if it is incomplete ring, high pressure will help you opening up. But if it's a total ring, OPN also may not help you. And that's the point you may have to do other strategies.
Yeah, exactly. Probably in this case, you have to take a lithotripsy or a cutting balloon or any of these. If you have a complete ring of calcification, I think as well, we may have difficulties to
yes, so the same case showed me the advantage of OPNs and the limitations of OPN also, and where to go for IVL.
The use of a wire, as Hiramat sir suggested, it may act like a cutting balloon. We say that poor man's cutting balloon technique is using body wire and dilating, right? So if you're using wire, that might just help to cut through the calcium. Although I don't know, I not used a body wire with OPNMC.
Next time I'll call MSH because he's my, as I said, favorite teacher. So all these tricks and tips comes from him.
I think using the cutting, I think the body wire with OPN is safe. We have a larger experience, especially when there's a concentric lesion. What we do sometimes, keep the balloon open, 90 seconds, 120 seconds, 2 minutes, 30-40 atmosphere continuously with cutting wire. Keep the balloon open, insist.
Keep which wire?
Yeah, insist with the time. Not only inflate 10 seconds, but give the time the balloon to open the artery. Well, also time is important. not just make a quickie with the balloon and wait until 20 years old lesion, calcified lesion get open. Even with body wire, keep time as well. 90 seconds, 2 minutes. My longest dilatation was 3 minutes with OPN, 45 atmospheres. And don't use cranioplast, such similar, but keep the balloon open. Time is also an important point. This is a crucial point to make to pointing. So not only 10 seconds, 10, 20 seconds, 90 seconds, 120 seconds, 180 seconds, 3 minutes, keep the balloon open. 40 atmosphere, keep the balloon there. And don't be aware. It's nothing can happen that the balloon can exploit, for sure, but not application. But keep the balloon long time open, and many times, sometime you have to persist and insist with many different balloons, diameter, cutting wire, and after 2-3 balloons you open that, you keep the mind, or you make like Pascal Meyer says, lithoplasty. You can do also that, but in Germany we have no reimbursement for that, and there is no so cheap. 100, I think 1,800 euro. This is not comparable with OPN balloon.
So what would have been your strategy? Suppose
means with OPN cutting wire with time.
Okay.
Time.
Okay.
Give time to the balloon to work. My longer dilatation was 3 minutes with 45 atmosphere. I can remember very well.
The this point of duration is very important, because if you deflate, bring the balloon back, to advance forward is very difficult because it loses its profile very easily. So you go to the distalmost point and keep giving high pressure so that you don't have to advance it again because you feel it's underdilated. So I think duration all the way from distality to the proximal end is the important issue.
And Max, I have a question regarding the cutting wires.
Yes.
Do you usually use 1 or 2 or 3? I usually use 1. I couldn't even say if it makes a big difference. It's maybe a bit more psychological, but still, in the standard I use one body wire as a cutting wire. Have you ever tried to use 2 or 3?
No, 1 is more than enough. 1 is more than enough, because you have to consider you push this stainless steel wire against the arterial wall with 40 atmosphere. It's cutting. It works, and we do that, for example, for ostial lesion surg, because the ostial lesion mostly also is the ostial lesion RCA. Because we try to cut with high pressure the fibrotic tissue. This is the reason why we combine for ostial lesion, especially in surg and RCA also, body wire and OPN combination, the preparation of the lesion. And well, there is no randomized trial, this is just register. But we started this new technique 6 months ago in German Center, and it's incredible how much pressure you can reduce your OPN balloon. Normally, you keep the artery open with 25 atmosphere with body wire. Otherwise, you have to go to 40 atmosphere with the same balloon. With body wire, you have to go 25 atmosphere. It works very, very well. It's just one wire, incredible. We might just take this technique only for ostial lesion right now, but it's experimental in German Center. I don't suggest to do the auto, but we do that, and it's safe until now. We are just collecting data.
If one wire is good, won't 2 wires be better?
No, just one wire is more than enough. One wire. Body wire with we personally use Pro Water and BMWW. The body wire is Pro Water because the stainless steel is very resistant steel wire, and straight the artery very well, and it gives you the possibility to cross also tortuosity with OPN and use the BMWW as workhorse wire and crush and your pro water wire against the arterial wall. It works. Try with ostial lesion CIRC, try with ostial lesion RCA, that's resistance lesion, and tell me the next time.
You should avoid polymer coated wires here, right? You should use,
Yeah.
otherwise polymer coated or jacketed wire may break.
Yes, pro water, yes.
Yeah, for both, as well as body as well as the workhorse, because even if you use it grips too much, as he specified.
Yeah, you can use 2 pro water wire or BMBW and pro water. This is the combination what I do with OPM balloon.
And Sachin, instead of using such a long 48 mm stent, now easily this time you crossed, but sometimes maybe good idea to use a 2 stent strategy if your 1 stent of 48 mm was not going to cross.
Yes.
Okay.
Also, Sachin, you know, you use Caravelle and Caravelle could not cross. You mentioned Tornus, but I think Corsair is much simpler than Tornus and clearly equal penetration compared to Tornus. So I would have probably taken Corsair. But generally, and whatever microcatheter you have taken, if it is not able to cross the CTO, I go with Guidezilla and the smallest balloon combination and keep the Guidezilla there only and use it for everything, including stenting till the end.
There is also a situation, I think this is the next case of Pascal, in which there are such situations with nothing crossed, even the Nick nothing crossed, even with Turnpike LP or with Tornus catheter, nothing is going through. And in such kind of situation, we have to perform something else. I think that there is a lot of things that you can do in case of not crossing with microcatheter. For sure, the Caravelle is not for antegradial approach. Normally, for antegradial approach, we use, yes, Corsair XS, for example, expression calcified lesion, Turnpike LP, for example, but Caravelle for CTO people like me are used just for retrograde approach, and not for every retrograde also. But for sure, nobody of us use Caravelle for antegradally if we want to find something. To the other hand, the Caravelle is a nice catheter, mostly for retrograde approach. I have to be honest.
I fully agree with you that Caravelle is not a very good catheter for antegrade. It's good for retrograde. It's slippery.
Retrograde, yes.
It's not for power.
There's no strength actually.
Yeah, there's no strength.
Yes.
Okay, so
but there is some case in which nothing cross.
Sorry to interrupt.
Yeah.
So we move on to Pascal's presentation. I hope your technical issues are sorted now.
I hope so now, yes.
Fire on.
The presentation should come from the office.
From the office. Could you please help?
So I will share your presentation, Dr. Pascal. Just give me a moment.
Thank you very much.
Okay.
So the title of my presentation is Heavily Calcified Lesion Preparation in the Modern Era. Exactly.
We can see that.
Excellent. And so then you can switch to slide 2. Huh? The patient is a 61-year-old male with 3 vessel disease and impaired LV function. Is it possible to switch to slide 2? Yeah. 3 vessel disease, impaired LV function, LV ejection fraction of 47%. He had a previous inferior ST elevation infarction with a PCI to his right coronary artery in 2009, and subsequently then was a bypass operation because of occluded right coronary artery. And in February 2020, he represented with a non-STEMI. The bypass grafts were occluded. He had a rot ablation and PCI to his proximal and mid LAD, and the PCI to the distal LAD. And at this point, there was also chronic total occlusion to the right coronary artery. Again, the bypass graft to the right artery occluded. And now he represents with angina pectoris, CCS2, shortness of breath, and NYHA 2 to 3. And he had a positive stress test with inducible ischemia in the territory of the right coronary artery. Okay, and he has, as risk factors, he has arterial hypertension, hyperlipidemia, diabetes, and a positive family history. But then you can show this first, the first film. Can you see the film? Yeah. So this is a dual injection of the, you see the left, the LAD, which is open with stents, open stents. The right coronary artery has stents, the proximal to mid part, and is occluded after that in the mid part with some collaterals from the left. And so we decided to do an antegrade approach to the CTO because there's even an appearance of a possible microchannel. This is a turnpike, an 8 French AL1 catheter to the right coronary artery, and then a turnpike LP, and the first wire fielder XTA. You see that the wire is passing the lesion quite easily, and in the injection there you see the distal segment, but then the guide catheter, the turnpike LP, just didn't cross. And so then you have the option of if you are not able to cross the lesion, to either modify the lesion or improve the support, or do both. And we did then use an anchoring balloon. You see the next slide, an anchoring balloon. Still the wire, a microcatheter wouldn't cross. Then the next slide. And so then the options are, if the microcatheter can't cross, one of the options are to use a rotowire and hope you get through the channel of the previous wire with the rotowire, or a Viper wire and use then a atherectomy. If you can't cross with a rotowire or a Viper wire, you would have to consider laser as the next step. We tried then a rotowire. You see here, we exchanged fielder XTA for the rotowire. Next slide. We advanced the rotowire, the rotafloppy. The floppy goes a bit easier across these narrowings in a calcified vessel. Okay. So here the rotowire is in place. And the next slide. And then, because there are previous stents in there, we used the smallest burr, 1.25, in order to avoid any kind of to avoid that the burr gets stuck. You see here a few runs of rotablation, and then the standard NC non-compliant balloon. And you see here is dock boning. The stent doesn't really open in the distal segment there. It's almost completely just a second, I need to see. Now I've lost it. Oh, there. Yeah. And then the stent boost projection, where you see that the stent is underexpanded in the distal part, the distal segment, which is of course a risk that a burr could get caught there. Oh, I somehow lost you again. Just a second, I need to check. I need to try to get onto my Zoom again. Anyway, you can see it at least, huh? The pictures. And then if, as a next step, if you have stent under expansion or stent malposition, you have the three options. Use a non-compliant balloon, a super high pressure balloon as open NC, or lithotripsy. We then decided to use open NC balloon, first starting with a 2.0. And as Max said, you have to really take your time, inflate it 12 times with, and each time quite a long time, with 50 atmospheres. And then on the next slide, this is a 2.5 balloon. And even there, you still see dock boning with, despite these several inflations at up to 50 atmospheres, with a total inflation time of 20 minutes. So you really have to take your time and be patient. And then the next slide. Unfortunately, I can see the slides. I can see it. I hope you're on the correct film. It's the one with the 2.5 open NC with 50 atmospheres, and you see there a rupture of the open NC balloon, which happens quite rarely. The balloon is so robust that ruptures are very rare. And then, as on the next slide, the next slide is with a 3.0 open NC balloon, again with 45 atmospheres, with again a dilatation time of 90 seconds. So, and then the final slides with the after the stenting, where you see kind of a good flow, good result with the skeletal distal vessels, which will probably remodel over time. But you see a kind of a very good result with this very high pressure, multiple inflations, and really taking your time. So you have to adapt, overcome challenges, and occasionally improvise. Okay, thank you. That's the end of my presentation.
Excellent presentation. Thank you very much.
Can you still see me? I'm somehow lost here.
We can. The
I can
transmission
see
is
you,
on.
Pascal. Just a picture of you, but we can hear you very well.
Well, you can't see me. Yeah?
Yeah, we
You can see just a picture of you.
Anybody has comments or questions?
Yes. Thank you, Pascal, for the very great presentation. This was I told before. You have to insist with your balloon dilatation. Inflated, I think, 12 time, 40 time, many time, different OPN balloon, and reach the results. Very complimentary. Most of the cases you do that after a very long preparation of the case, because for a very long preparation with rotablation and OPN balloon, and this is not usually to see such preparation of cases. What do you think, Pascal, is the option with lithoplasty in the future in such cases? Because in Germany we had some issues, but this is the reason why we have not much experience with lithoplasty. Do you think that the modification of the plaque with lithoplasty in such cases like that better works than rotablation and OPN? Which is your experience about that?
Now, I have to confess, I don't have much experience with lithotripsy either, because also here in Switzerland it's not reimbursed. The costs are very high. It's not as easy to use as a balloon. Takes more time. The balloon is bulkier. There's a lot of I think still a lot of negative aspects of the lithotripsy balloon. In my experience, if it's really completely circumferential calcification, there is a certain, I think there is a role for lithotripsy. But otherwise, I think as long as you can go with the standard, easier tools like OpenNC, that's worth it for me. Or then using this as you mentioned, this body wire, also the cutting wire. And so far, I managed almost all lesions to prepare almost all lesions with this. So I think for lithotripsy, it's a very niche for very few cases where you really can't open the artery with an open NC balloon. But otherwise, I think that's the much preferred option now. Again, for cost reasons and the whole learning curve and the bulkiness of the device.
What was the size of rotor you used here?
Pardon me?
Rotor burr size.
1.25, the smallest one, because it was in a stent, just to avoid the stent, the burr gets trapped.
So I would say probably using a 1.5 mm burr may help.
Yeah.
I used rotor burr for in-stent restenosis as well. So actually burr wouldn't get stuck, not necessarily. You can shred the stent with rotor burr as well. So that's what one thing could be done is upsizing the burr so that the lesion gives away. Usually it's maybe 360-degree or large nodule of the calcium, which is compressing the stent from outside.
Mm-hmm. Yeah, that's a good point. Absolutely. Yeah.
Which is you removed your CTO wire and you moved with the rotor wire.
Exactly.
Why that? I mean, you removed the CTO wire.
Yeah, exactly.
Okay. So can you explain this concept? Yeah. Because
to place a rotor wire is, of course, to go all the way down with the microcatheter and then exchange the standard or the CTO wire with the rotor wire. But if you don't manage to get down with the microcatheter, you have to, you're a bit limited with the options. And then one way is to one option is then to try to remove the CTO wire and use the channel of the first wire to pass there the rotor wire, so that you are then able to rotablate the lesion. I mean, there are other options as well that you could try, like the granuloplasty or a double wire technique, where you could put a second wire to cut a second, kind of like a second hole and get more space, or use laser. There's a few other options, but I think the most elegant one is to, especially if you anyway want to rotablate, is to try to use the rotor wire through the channel of the CTO wire. So that's why you have to exchange them, because at the end you need your rotor wire in the distal part of the vessel to be able to advance the rotor burr.
I think it almost always works. Like you pull out your CTO wire, microcatheter is as deep as possible, and through that you put your rotor wire. It almost always goes.
Yeah, it's astonishing because the wire feels very kind of, it kinks very easily. It doesn't feel like a very good wire for handling, but my experience is the same. It kind of works surprisingly well, exactly, especially if you have a track already from a previous wire to then go with the rotor floppy. Or what's your experience? What are your experience, Max, with the rotor floppy wire?
The floppy is the workhorse wire also for us in German Center. I find very interesting this concept of removing the CTO wire. Don't be afraid to do that, because like CTO people like me, we are afraid to remove the CTO wire, especially after 1 hour of job.
Yeah.
And to jump to the rotor wire, for sure, this is a nice idea, a very elegant idea. And let's say it was Dr. Shirish from IRMAT, it works because you put your microcatheter deep inside and maybe you torque the wire and you cross in the same microchannel created from your CTO wire.
And also the diameter of the rotor wire is much smaller than the
smaller. This is the teaching point. This is the teaching point. The diameter is smaller. Yes.
So your microcatheter is actually telling the rotor wire which way to go, and it's probably easier for it to follow the course of the earlier one.
Yeah, very excellent case. Thank you.
Okay, there's a question from the audience. In this case, OPN was inflated for 20 minutes. What is the recommended time for inflation?
I mean, that's not I'm not sure who can answer that. I don't think there is a really recommended time, but I think you can't. The longer the better in general, or as much as you need. If it works with a short inflation, that's fine. But if not, then you just have to have patience. Not give up. If it doesn't work with a few seconds inflation, you just have to take more time or use this body wire, this cutting wire in addition.
In the early days, there were a lot of studies about the duration of the balloon inflation. So this was true when we do a balloon dilatation for pre-stenting, as well as when we inflate the balloon with the stent. And I think most of the people agreed that more than 60 seconds does not serve any purpose. Like up to between 15 seconds and 60 seconds, it makes a lot of sense. But from 60 seconds to 3 minutes doesn't make any sense. Why is it different with an OPN balloon? The length of the inflation, duration of the inflation.
I think we are talking about undilatable lesion, isn't it? For the stent, we will inflate maximum 30 seconds, where there's not much of under expansion. But if the lesion is like this, where it's not giving away, then I think the longer the time, more the chances that you can dilate the lesion, right?
I mean,
no, but earlier studies have clearly indicated that the duration doesn't matter. So here, you are trying to say you keep expanding, increasing the pressure inside the balloon, or just you achieved 45 and just stop at 45. Is that correct?
I think you're just giving a more time for the lesion to give away. So only pressure is not the factor. The time will be also a factor, as Dr. Fusaro was saying earlier.
In our experience, I have to insist that point. So, as Pascal Meyer demonstrated, if you insist, you achieve the result. So, Dr. Sawan is right. This is undilatable lesion. There's not a stent. There's not put in a stent. There's no rules. There's like in the Wild West. You have to achieve that. You can't use nothing else like lithoplasty, but you don't have lithoplasty. The only way what you have to insist on don't give up.
That's right.
I can understand the sense of the last picture, improvise, overcome. I understand now the sense of your last picture, improvise and overcome. But sometimes we give up because of a lot of things. We don't believe that the lesion gets open. We don't believe a lot of things. Our preparation sometimes. Moving progressively with diameter of balloon and insist after you reach your pressure there with many dilatation, at least 90 seconds. I want to suggest try at home in your cath lab and tell me next time. If you don't believe me, try that. Especially with body wire, you reduce time in dilatation. But our experience is important.
Should it work for only regular balloon also? I mean, only for OPN this
only
duration?
For OPN. So undilatable lesion don't make sense regular balloon. So don't waste your time with something else.
Okay, so next presentation is by Dr. Rahul Gupta, as Dr. Praveen Kahale is not presenting anymore. So for Dr. Gupta, post-stenting undilatable lesion treated with OPN NC balloon. Can you share your presentation now, sir?
Okay. Can you see my slides?
Yes.
Yeah, so I think in continuation with whatever we are talking, I have a similar kind of case. So this guy, 68-year-old male, hypertensive, diabetic, bypass surgery in 2006. He presented to me last year, severe LVF and non-ST elevation MI. He was put on ventilator, weaned off in 2 days. His LV ejection fraction was pretty low, 15 to 20%. And creatinine was initially high, which settled to 1.2 with conservative management. And after 3 days, this was his angiogram. And if you look at, there's a native calcified TVD, LED mid total, LCX major ohm shows total occlusion. RCA, there is the RCA, the one which, so this was the RCA where we see, there's a calcification in the proximal lesion, calcification in the mid part. Then there is a, the distal at the crux, there is a calcification as well as a tight lesion, as well as there is a curve over here, a band kind of thing. And we can see a tight lesion over there. So there are multiple lesions. And the other thing which I wanted to point out in the previous, that the diagonal was also unprotected and it was, it was tight lesion. So this patient the graft to the OM were okay. The Lima graft to the LED was okay, but there was a distal disease after the graft, as we can see in the Lima, and the SVG graft, which was given to both the PD and PLV, it was occluded. These are some of the views. Now, there are various thoughts when you have a patient whose EF is low and there's a calcific lesion. There are other, there was a tight diagonal which was there. So these were the thought which vessel to intervene, and stage wise or at one go. So of course I decided RCA because it is a bigger vessels, and maybe later on the diagonal, which was also big. So this was my approach. Now, so this is the lesion now. So, as we discussed, there is a proximal lesion, mid lesion, a distal lesion in the RCA, and then there's a lesion in the PD, and there's a curves. There are multiple curves which are there in this area. The issues like which kind of guiding I should use, I thought of using IPR, thinking it will be coaxial if I need to do rota, keeping in mind that it may not give adequate support while passing the stent curved arteries, but that's what I chose. The issue with the rota, EF was on the lower side, the proximal vessel was big, so I thought 1.5 bar would be required for that debulking, and PDA a 1.25 bar because it's a smaller vessel in case it is needed. I was hoping sometimes we get these kind of patients where the lesion looks very calcific, but when we try with the balloon dilatation, surprisingly they dilate, and then we are able to avoid rota where we want to avoid because of the curve, because of the low ejection fraction. So the wire, this was a routine workhorse wire. It passed easily, and the balloon was dilated. So these are all fluoro images which were captured. It looked like that the balloon is is getting dilated, and I tried, we always try to see whether what is happening with the lesions at low pressure before we go for the rota. This is what I usually do. And if they are giving way in the, at a lesser pressure, then we know that avoid. So, I dilated, pre-dilated distal, mid and proximal RCA, and it looked that the lesion is giving way. So we have the, the balloon on the left side. This was a 2.75 balloon initially. It looked that, probably I'll be able to get away without rota. So the idea was to stent the distal thing and then the proximal thing, but the stent did not cross. So I thought, let me take the 3x12 NC. And so these are 3 into the NC dilatation. And if you look at the fluoro image, the balloon expansion looks okay. So, these were some pre-dilatation which was done with the sequential balloon. Sorry, the sequence is little, before and after. So these were the dilatation which happened with the higher pressure, and this was the PD which was, not giving away. There was a tight lesion over here, and I wanted to stent the PD to from PD to the distal RCA, but this was not giving away. So PD lesion was not giving away, and I thought, let me take the OPN balloon, but the OPN balloon, I think this support was not adequate, and it was backing out everything. All the system was backing out, and it was not easy to cross. And then as we were discussing, that I'll take a buddy wire. So buddy wire initially did not go, but then I pre-dilated the lesion again, past the buddy wire, as we can see, and pre-dilated with at high pressures again, but the lesion did not seem to go away. And so these are some of the images where the balloon still doesn't look dilated. The distal RCA is okay. There's no dissection in the PD area, although it's not as we want. So there was no dissection, better than before TIMI-3 flow. Thought of leaving the distal RCA at this moment because the time it was taking with low EF and all. Then I dilated the mid with the 3ONC, and it looks expanded. So I thought, I can now stent the artery directly, and it would expand, and then I'll do a post dilatation. So this was 3.5 into 38 des, which was implanted. And this is how it looks now. The stent is not open in the mid part, although the balloon gave the reflection on the fluoro that it has opened up. And then I wanted to dilate it, 3.5 into 8 and 3.5 into 9 at 30 atmosphere balloon bursted. So these are some post dilatations. Now I tried to cross the OP&NC, but I think with the workhorse wire as well as the guide which I had, it did not seem to cross. So then I used a guide liner, took it till the lesion, the undilated part, but again the OPN doesn't seem to cross at this time. Now I had a colleague who was there with me. He, we were tired, nothing was crossing. So one of his suggestions was remove wire, take minor shoot and leave it. I thought, no, we should fix this up, and we can't leave the lesion like this. So I changed the guiding, AL2 Grand Slam wire, which was little difficult to cross. And it took AL2 Grand Slam wire guide liner support to cross the lesion. And then the OP&NC opened at about 45 at a prolonged inflation, as we were discussing, that you have to wait, have patience, and then it gives away. I'm stuck. Sorry, there's an issue. This is not moving forward. Let me. So basically, the results were excellent. The balloon completely opened up. I'll try to see whether I can go forward. So the balloon the balloon opened up, and then it was good flow, adequately, completely dilated. Sorry, my laptop has got hanged. It's not moving itself. So.
Okay, so no problem. So excellent presentation. I think you can fix the laptop, and maybe at the end of the session you can show the.
Maybe I'll try once again. Maybe take it directly to the final results.
Yeah.
There's something wrong. I think it's the previous one also.
While he's fixing the laptop, any comments or questions?
Yeah, it's showing not responding, some issue. So see, the final results were okay, and I think so I think the message which I learned, sometimes we think that let us go easy, simple, and sometimes we underestimate the calcification, and we might have to take multiple views to see whether we sometimes try to guess on the basis of the balloon expansion that it has adequately expanded, and then we try to put the imaging definitely would have helped, but in Indian scenario, sometimes we try to look at the cost of the patient. We want to minimize the cost, and sometimes we cut corners by not using imaging. So imaging would have helped, and maybe assessing the fluoro in different views, and whenever there is a calcification, whether it is adequately expanded or not, because otherwise I would have done pre-dilatation or used rota as the after the. These are my thoughts.
I think, Dr. Gupta, whenever there is a post-cabbage intervention that we are planning on a native vessel, we should almost presume that the native vessels are going to be hard, difficult to handle. So that is one dictum which I always follow, because If you see, you put a graft and within 6 months, the native vessel is completely occluded. So probably soon after bypass, this vessel was completely occluded, and the CTO is probably such a long duration that you had. So obviously, I mean, this was not a CTO, but every reason to believe that it's going to be a very hard lesion. So I think we should be prepared to handle a very hard lesion when you're doing a post-cabbage intervention. Same in Dr. Sachin's case too.
Yeah. So the thing is that, we are prepared with that, but sometimes you think that, maybe we'll keep it safe and simple and completed, and then you'll end up in these kind of situations. And I think as we all were discussing that if we have all these hardwares with us, I'm not able to show the last thing, but the results were excellent. So I thank, I had a OP and NC that day, otherwise I would have no other options at that time to do.
The lesion preparation is the key for all these cases. Yeah.
Yeah.
So we'll move on to the next presentation, which is by Dr. Bajrang Dubey, ultra high pressure at LCX complex lesion. Dr. Dubey, please.
I'm working at Peripheral Center in Latur, Maharashtra. The patient was 70-year lady, presented with history of angina and dyspnea. She was known case of hypertension, and ECG was suggestive of infralateral wall MI. She was thrombolized successfully, and we did her CAG. And circumflex was culprit artery, which was codominant with heavy calcification in proximal and mid segment. There were 2 tandem lesions in proximal and second after OM1.
Will it be possible to see CAG?
Yeah, I have shared screen. Screen is not visible, sir.
Screen is visible. We can't see the CAG.
1 minute, 1 minute.
Actually, we can see on the left-hand side only 4 slides. So probably this is not the right presentation that you're showing.
Yeah. Hello. Now?
Yes.
Yeah.
Yes. So 2 tandem lesions, and there was also disease in the inferior branch of the OM1. So I went with the initially 2/12 balloon, which was expanding well. Dilated both the lesion, proximal and the distal. There was a good pre-dilatation with it. Then I tried again, went up with 2.5 and 3/0 balloon because it was a large vessel, and tried to cross the stent, but stent was not crossing. So I also tried with guide liner, but I failed the attempt. So finally I tried with the open NC and went up around 35 atmospheric pressure, and the subsequent crossing of the stent was very easy, and inflated the stent at the 16 atmospheric pressure, and there was a good result.
Is that it?
Yes, sir. Yes.
Now, I mean, excellent result for that vessel, but it's a bifurcation lesion, and the other vessel is also good size. It's a left dominant system.
Yes,
so you did not treat the OM, which is also diseased. So you could have also used here a bifurcation strategy. Also, we need to note that there's a lot of calcium at the ostium of this OM.
Yes, sir. Yes, sir. Patient was a little unstable, so I thought to go with provisional stenting only. There was a good flow in the OM1, and I planned the OM1 intervention later on.
Okay.
But did you do the pot, and what was the size of the pot balloon?
Sir, that patient not turned up again. That some financial problems. Yeah.
No, not for the future intervention. You did by provisional. So the proximal circumflex, did you do the proximal optimization, and with what balloon?
For the same, the stent was no pot, sir.
Okay.
Sachin, basically he was not trying to address the side branch.
Yes.
So he has post-dilated the entire length of the stent and not done it as a separate pot for the side branch access.
I mean, see, for the future, if he turns up, life will be easier for you if you do the pot.
Yes, sir. Yes.
I have a comment for the guideliner in the circumflex. I think in the circumflex you have to be very careful with to see how the flow is into the LAD. Occasionally you can really kind of hinder flow into the LAD. It's very different to the right coronary artery, but the guideline is an excellent tool. As soon as you're in the left, especially in the circumflex, you may hamper the flow to the LAD, so I have to be a bit aware of that.
So when you use the guideliner, there'll be pressure damping, and the operator does not get any idea what's happening to the pressure. So whether
exactly
or not, and then you may end up patient having VF, and then as an operator you don't understand what's going on, right?
Exactly. Or if you don't give enough heparin, the LAD may thrombose, or you can run into problems there. I have to really be careful. I don't use a 7 French guideliner, and if you use a guideline, just be aware of that.
Sure. Good point, sir. Okay, so I think we'll move on to the next case, which is by Dr. Neeraj Ragani. Neeraj, you there? So he works at Zenith Hospital, Amravati.
So am I audible and my screen is visible to you?
Yeah, your screen is visible.
Yeah. So like we have done in the session, I'm presenting a case of undilatable lesion, and now as we have refill, we can penetrate more into the enemy area, and we should not leave any stone unturned. So this is a patient, a 72-year-old male who came from Nigeria, and the relatives were here in Amravati and had an angina, progressive angina, and came to me for progressive dyspnea and angina over the last 3 months. It was ECG and echo was normal, and the biochemistry and the hemoglobin, everything was normal. And straightforward with the clinical history was taken for the angiography. And the angiography was done, which was showing a good and normal size, good size left main with the proximal circ was good. The circ beyond OM was having a tight type A lesion, and the left main was having a calcified plaque. The proximal LAD was having a calcified lesion followed by a tight lesion after the diagonal. And the RC, this was a tight LAD, which was, I think, the culprit lesion. And the RCA was a moderate size vessel, and there was a tight lesion before the crux. I don't have any other view for RCA, but there was tight lesion. So my plan was with this case to straightforward to go ahead and do the circumflex, and then come down and do the LAD, only the focal lesion, and not to come to the ostium of the LAD, and not to touch the left main, and do the FFR after opening the mid-LAD, and then take a call whether we need to do the left main or not. So circumflex was a straightforward lesion, though mildly calcified, it gave way with a balloon followed by a stent. This was a 323 Zions, and the results were excellent. And then I went to the LAD thinking in the same way that it's a simple lesion, and I took a 2.5 non-compliant sprinter balloon, and I went up to 18 atmosphere and kept there for 30-40 seconds. But it was not giving way. I did this for 3 to 4 times, and I went maximum up to 22, where the balloon gave way and ruptured. And I have to take out the balloon, and the lesion was still there like that only. So I don't have imaging with me. So it was a tight calcified lesion which was not giving way. So I took an open NC 2.5 by 12, and I went up to 40 atmosphere, and I kept there for around 40-50 seconds. And then I took a shoot, then still the lesion was not giving way. And again, I put my open NC and did this 2 to 3 times, but the lesion was not giving way. I have not put all the slides here, but I did several times before taking a decision that we need to burr here. So I took 1.5 burr and drilled the lesion. And while I was daughtering my burr, I could feel that it's tight lesion. And even after dilating the OPN at 40, even the burr was not going very easily. So it was a lot of calcium which was not giving way really. So the lesion got modified. Then I thought now the lesion has got modified, the elasticity and the things are good. So I took again the same 2.5 NC balloon sprinter and dilated. Then again the waist was still there, the similar waist which was there initially, and it was not giving way even at, so sorry, this is another NC balloon, and this was also not giving way. And my first open balloon was also ruptured at 40 atmosphere. So I lost 2 balloons. So this is my third balloon, a sprinter balloon 2.5, which was not giving way. After doing rota, so I was clueless what to do here. I don't have lithotripsy with me. I have done 1.5. I could not upsize my burr. I don't have 1.75 on my shelf. Even the cost would have gone too high if I, and even I have used one open NC, one rota. The cost has already gone very high. So I have to think about the expenses also. But the lesion was like that only. Even after doing rota, twice I have used non-compliant balloon, one open NC. Now what to do? And then this patient was a father-in-law of a physician here, and that physician was standing on my backside, and he was looking at me what I'm doing, and I was just my commentary was going to there that I'm not able to give open the lesion, whatever I'm doing. So he told me that should we send this patient for CABG. So I told him, let me use another open NC, and then I took another open NC, and then luckily, to my luck, this gave way at around 40-44. And then the things were straightforward. And this is the most tight calcified lesion I have come across till date. Then I put took a stent straightforward, and stented the lesion, and the things were good then. And I got I think excellent result. After that, I did the FFR. The FFR was negative, so I not touched the hostel LAD and the left main. So this was my case. Thank you.
Okay, so
I
great.
think I'm done.
Thank you for presentation. I think a few points to note is better not to have a relative inside the cath lab, especially if it's a physician or doctor, because it puts a lot of pressure, I guess, on the operator and for legal side also.
Yeah.
With regards to OPN NC, I think you did a great job. But my comment is, if once you dilate with NC balloon, it's risky to put a rota wire. Okay, so
Yeah.
you exchange with some catheter. Did you use a fine cross-like micro catheter to exchange?
Here in this case, I have not used, because there was no major dissection, flap was not visible. Though I use a micro catheter, but here I straightforward crossed my rota wire, and then I took my another wire out and straightforward went away with the rota.
So you should remember that you may go into dissection plane, and then everything may dissect when you are going to use a rota wire. Yeah. Also, one of the, it's not a contraindication, but one thing I've been taught is you should not dilate before doing the rota. And yes. That's one of the being cautious or kind of contraindication. People have done it, but it's again risky to do the rota after using OPN NC or any NC balloon, because
I was aware of that, but I do not have any choice there. Initially, I thought it's a simple lesion which will give away with open NC, and open NC was new. It was done in Feb So I think OpenNC was very much promising at that time. It was new, and it was not the first time I used OpenNC.
People tend to underestimate the calcium. So whenever you're doing a diagnostic angiography, first few seconds, just do a dry cine. And when that dry cine, if you see tram track like calcification or heavy calcification, I think there's no point in thinking that you're going to get away easily with that lesion.
Yeah, but what's your opinion, Hiremat sir? After doing such a high pressure balloon dilatation, how comfortable you are using rota, and what are the complications you have seen? Like,
I think we all worry about the dissection because if the vessel is dissected, to go through it is not safe. So I would probably feel that if you used a small diameter balloon, especially a non-compliant balloon, I think you're reasonably safe using rota.
I think the first open OPN balloon failed and second one succeeded. So I think that is the rota effect. That see, the rota not only gives us whatever eccentric wire bias and cut, but it helps opening it. And the second is it fries the lesion. Even if you have not, it just hits up the lesion, and that's why the next OPN gave the way and after a sustain. So that's the issue. But I have again two things to say. One is that, see, your rota wire was having a perfect hairpin U in the initial part. So how safe it is, maybe the experienced operators can comment, because I generally fear that there should not be a bends in the rota wire, because it can really cause a trouble and churn out the lesion or distal lumen. And second is, I think Rahul has adequately highlighted that predilatation, that to be that high pressure before rota can put us in difficulty at times, but you could manage it. So that's great. So what about wire, Dr. Fusaro or Hiremat sir, what you feel that U-shaped rota wire was there, how safe it is and can it cause issues?
I don't suggest to do that, but sometimes the rota wire is knocking for himself. It's not a big issue, it's not a big problem if you don't move the rota wire too much. The only complication that I remember with rota wire is to me, is the rota wire is going sometime jumping, because the jumping with rotablator, removing rotablator and going inside with rota, can jump in small branches. For example, septal branches. And septal branches with knuckle wire, even with rota wire, are quite fragile. So I don't suggest to keep the rota wire in knuckle manner. Better to go with the microcatheter inside and to remove your rota wire, or remove the knuckle of the rota wire, put it out quite distally. Microcatheter must be a part of rotablation. This is the point. This is the crucial point we're discussing. Microcatheter is a crucial part of rotablation because it's safe to move to put the rota wire through the microcatheter. You can manipulate much better everything. But I want to make a comment about this case, if I can. This is an example of insist and insist and insist and delay and delay and delay. You give it your result. Even the rotablator is not able to crack the lesion, but just to prepare. This is the concept. This is the people what they understand. Most of the people where I make proctor, and they told me I don't need OPM balloon. Why? Because I rotablate too much. Okay, take distance from the skies. Because it doesn't exist. I rotablate too much, and I don't need OPM balloon. That means you don't treat even calcified lesion. Because mostly, like Dr. Shirish said before, it's a combination. It's a combination, rotablation and OPM. And in this case, personally, we had to use the body wire and delayed and delayed and delayed. It's the only way in what you do. The rotablation step was necessary to prepare the lesion to be cracked with OPM. This is a crucial point. That's the teaching point that the people have to understand. if you don't have rotablator, better don't start a program of very complex high-risk procedure, or refer the patient in this case in another hospital in which can do that. Because sometimes I remember one case in a country in which it was impossible to dilate the lesion even with body wire, and we make rotablation. With rotablation, in a couple of minutes, the lesion was open. So the teaching point in this case, my opinion, is the combination. And the second teaching point is keep open the balloon and insist to dilate. Insist to dilate. And what you did. That's why I compliment for the case. Yes.
Thank you very much. At one time I thought let's leave it, but then it gave way. Thank you.
Yeah, this is the crucial point. There's a keep open, insist to dilate. You rotablate, you prepare the lesion. Everything was in the right way. It's just a matter of time when you reopen the artery, when you crack the lesion. It's just a matter of time. Don't be afraid to insist and dilate, because you make every step correct, and it's just a matter of time. You do that.
Yeah, the intervention cardiologist never leaves the battlefield.
Never left the battlefield. I learned that. But I learned also from a very old school guy, and he told me at that time, if we start in the cath lab, you know when you start, but you don't know when you finish.
Yeah, great. So perseverance is the key, and not leaving things for the surgeons to handle later on is another key, because if such cases go to theater, then I think the mortality is high as shown by the data.
Yes.
So,
I can remember one case of perforation of left main in German center. I can remember very well the case. Was a very experienced operator, not me, but it was a very experienced operator. And we were able to put a stent in left main, current stent in left main. We put an impella, we put an ECMO, we made also pericardial drainage, and we sent the patient because of occluded circumflex to the surgeon. Believe me, what happens after that? Can you tell me?
They cannot access the perforation in the left main side. So they are going to be only in the distality. They might put a graft to circumflex.
Yes. So we was able to manage the perforation left main and put a stent left main LAD. We reopened the LAD, but it was impossible to make the puncture of the stent struts to recross the circ. So we sent this, for this reason, the patient with ECMO, intubated, pericardial drainage to the surgeons. She died because operation circ. Sometimes if you leave a myocardial infarction there, maybe she survived. So this is a tragic history in which what I can tell you. Sometimes if you want to do too much, also with surgeon, the surgeon cannot help us. This is our experience. Nobody wants to take something from you. Nobody is happy to take some complication from you. Nobody. And we have the surgeon at home. So since this time, we create a lot of protocol in which we can reduce the probability of complication. Prepare yourself for the complication. This is the philosophy. It's not a big deal. Create protocols that reduce the time in which you can react during a complication. This is one of the most important teaching points. This is not a complication session. But if you want to speak about sometimes the complication session, we have to understand the complex PCI, we need to be prepared also for complication. Otherwise, it's just a matter of time. This is just the complication is waiting for you. And if you are not created protocol, if you not created quick reaction protocol for your complication, mostly it's a perforation. But I can remember one patient, in this case for me, During recanalization circ, I create a big hematoma in the artery, in the muscular wall. This was not a complication at pericardial effusion because kept. You create an hematoma of the wall, what we call dry tamponade. Dry tamponade is the most dangerous complication what you can have in CTO. Dry tamponade is an hematoma of the wall of the ventricle. It's not possible to make a puncture. And we managed all the night the patient with ECMO, and the day later we sent the patient to drainage this hematoma surgically. It died, but it was stable with ECMO. So sometimes you guys keep in mind, well, you create a complication. If the patient is stable, keep the patient stable. Don't try to do the best, because sometimes the best means death. This is our experience. So prevent the complication, most important thing, prepare yourself for the complication. The most simple complication, what you can have, you must be happy to make a pericardial drainage. If just the rupture of the artery is the simplest complication what you have. Dangerous complication is no reflowing left main or the dry tamponade. You have no chance to make a pericardial drainage. There's an hematoma of the wall, of the ventricle wall. You have no chance to stabilize the patient with ECMO or Impella, better ECMO, and wait the reabsorption of the hematoma. This is the way.
I think the perforation in a post-cabbage situation, that is also extremely dangerous because
dangerous, extremely dangerous.
The blood has no space to go, and it will compress on the heart immediately. So
this is the dry tamponade. What I mean, this is an hematoma compressing the wall of the ventricle. You have no chance. You have to put an ECMO, exclude the ventricle completely, and wait a couple of days because the hematoma resorts.
And
but
don't send them to surgery. And don't send them to surgery.
Don't send to surgery. Don't send to surgeon. Don't send to the surgeon.
I think there are papers which state that patients going from cath lab complication to surgeons, the mortality is much higher compared to if you manage them conservatively.
Sure.
The chance that they will survive managed conservatively.
But interesting to understand that the pericardial effusion is not the worst complication what you can have. This is important to understand that. The second teaching point is the quick reaction protocol of your complication. For example, everybody have to know where is the pericardial kit to puncture. Everybody in the cath lab have to know. Where is that? Where is covering stand? How we can put a covering stand, for example, ping pong technique, such similar things. You need to do that to teach the people to learn that also. Because sometimes we work a lot and sometimes everything okay, but it's one patient in which you have your complication. You remember that. You remember that because you don't create the quick reaction protocol. Nobody know where are the covering stand, which kind of covering stand you have, which kind, the old one, the new one, how you put your covering stand, reversing heparin, how much, nobody. This is the crucial point in which nobody have to think, but just react.
I think what is obvious, like a perforation, is probably easier to handle because you realize it immediately. It's these distal wire perforations, yes, which you miss when the patient is on table. Like you don't see it when patient is on table. You shift him, and after 6-8 hours, maybe at middle of the night, the pressure starts dropping. And these are very difficult to sort of, I mean, to make a diagnosis also is very difficult. Yes. So that it takes time. That's where I think the reaction time is very long. And I think something which is very easy to salvage gets not salvaged only because of the delay.
This is the case what I had the perforation of the small branch of the septal branch. Most of the operators are concentrated to see the final result. Those small perforation of the septal branch are forgiven. No, Nothing is forgiving. The perforation is a perforation. It's not forgiving. The perforation is bleeding all the night, like Dr. Shirish state right now, and you are called in fear on 4 hours in the morning to make a pericardial drainage.
The important point here to remember is when you finish your case, go back to the console and see the last couple of runs for longer period of time. Also, take a shoot for a longer period of time until you see a coronary sinus phase. This is what I learned, and this is very useful. Second thing is,
Rahul, I must add, take the last picture yourself and not leave it to the fellow.
Yeah. And you can make a simple decision like not starting tiropivan. So if you see a small wire perf, do not start a tiropivan. Many times we don't see it. You start tiropivan, and then after a few hours, you're going to see a huge tamponade and pressure dropping.
The bleeding, yes.
Okay, so I think we shall conclude here. We started a little bit late because of some technical issues. I would like to thank our chairpersonnel, Dr. Hiramat, Dr. Fusaro, and Dr. Mayer. I would like to thank all the presenters. I think it's been a great case discussion. We learned a lot from each other, and I would like to thank TransLumina for giving all of this opportunity to have an online discussion. Thank you so much.
Thank you very much.
Thank you so much for all the participants. Thank you so much for joining us. So we still have one more day in Maharashtra BIC. So tomorrow we start at 10 a.m. till 2 p.m. We still have the conference on. So we will see you there. Everybody can join us on the viewers link tomorrow.
Thank you.
Thank you, Pankore. Thank you very much for your efforts.
Thank you so much, Dr.
Thank
Fusaro.
you.
Thank you.
Thank you,
Bye,
everybody.
Thank you.
Dr. Pascal.
Thank you all.